I'm Charlie Sabatino, I'm Director of the ABA Commission on Law and Aging. But to speed things up, I'm going to dispense with introductions because you have a little blurb on everybody in your materials. So let's dive into this first session. Is titled Advanced Care Planning, Shared Decision Making, and Goals of Care. We have a format in which I'll make some introductory remarks. Four panelists will each give a short perspective on this issue. These are not going to be long-winded treatments of the issue. We want to get your thinking going. We want to get discussion going. And the discussion part, which we hope will be a good half hour, 45 minutes, will be started off by Dr. Stephanie Pincus, and then we invite you all to join in the discussion. We have one floor mic here, and is there another one around also? And so we will get going. So the topics of this session are, I think, an indispensable part of the array of palliative care. So to get our discussion going, I'd like to propose a vision where we want policy and practice to be with respect to advanced care planning. And it is this. All individuals experience an advanced care planning process that allows them to express their values, goals, and wishes for care, informed through an honest assessment and understanding of their medical condition and facilitated by shared decision making. The result is a plan of treatment and care consistent with their goals and values that is honored across time, place, and provider. This is a vision that our panelists all agreed was a good starting point. The barriers to that vision are many. Most of you could probably write treatises on them, so let me just bullet what I kind of think of as the intransigent 10 in my mind. One, overly legalized advance directive laws that hinder rather than promote advanced care planning. Two, lack of flexibility among state laws and policies that too often make them unfriendly to social and cultural diversity. Three, the clinical unhelpfulness of most standardized advance directive forms. Four, the lack of effective protocols to incorporate advanced care planning documents into actual plans of care that follow patients across care settings. Five, the lack of recognition of advanced care planning and how we pay for care. Senator Warner had something to say about that. Six, the lack of effective public education, engagement, and acceptance of advanced care planning as an important lifelong task for all adults. Seven, the inadequate access to long-term person-centered supports and services in the community that are essential to enable seriously ill and dying persons to live and be cared for how and where they want. Eight, the inadequacy of professional education and training in advanced care planning, resulting in disregard or misperception of advanced care planning documents. 9, the absence of systemic approaches to integrate advanced care planning into health systems, in the office, in the hospital, and in the community settings. And finally, 10, the lack of understanding and support of the difficult role of the healthcare proxy and default decision makers. So we could spend the day battling and amplifying those barriers, but what we want to do is to get everyone to think creatively and effectively on how to move ahead in the field. What we can do to overcome these and other barriers that you are aware of. So with that starting point, I'll ask our first panelist, Judy Peres, to share her perspective.
Everything turn, 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 there is a season, turn, 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 and a time to every purpose under heaven. A time to be born, a time to die.
So I had to use that as a tribute to both Pete Seeger and the concept of normalizing death. And Pete Seeger obviously is a model for us of what it would look like to really be able to empower and engage communities in looking at what it takes to have good end-of-life care. I am thankful to the Center for including me in this panel today. I'm among colleagues that I know that have been at the forefront of this since its inception. Not that they were there at the beginning of death, but they've been there sort of being champions for having good deaths throughout our lifespan. I'm going to spend my few moments here on the advanced care planning panel reflecting on both our need to empower individuals, families, and communities, and also try and identify some of the elements of systems change that could provide perhaps a default glide path, which would automatically then include advanced care planning and care planning, or perhaps even in PULSE, the physician's orders for life-sustaining treatment. I'm speaking to you today from the vantage point of both a palliative care clinical social worker and a long-standing health policy analyst of over 40 years. I came into Medicare with the 1972 amendments and ESRD. In fact, the concepts of engaging people and their families in the discussion about planning for care and our society's health and social system failure to deliver the care that they need and want are very much intertwined. As our technology advances, instead of continuing to experience and normalize death as part of life, like the song teaches us, we have removed it as part of life. There's an important dichotomy we must address at both the individual and the societal level. On the one hand, people and their families fear death, often can't actually see death as imminent, even when it's right in front of them. And on the other hand, people want autonomy and they want to die as they choose. Their preferences, values, and wishes need to be honored. This, in large part, is the discussion about advanced directives and advanced care planning that we've just spent 40 years having. I'm also honored today that among my colleagues are both the Center and Charlie and Neil, who were all instrumental in helping to write the report to Congress on advanced care planning that was issued the month before the death panel fiasco. So you all may not know of that report. Sadly, we see this playing out once again in the media and in our national dialogue. I want you all to bear with me a little bit because I'm going to go off the reservation here, but I know that the panel and our good work today are going to bring us back at some point. As a society, we're conflicted and uncertain and imprecise about death, even when it's clear. The tragic situations surrounding the two brain-dead people highlighted many aspects of our challenges in engaging the public about advanced care planning. I know I'm traveling into territory here that we're not really talking about today, but I want you to see it as a way that we're dealing with in terms of the public engagement. With Jahai McMath, what hopefully would have been a routine surgery where she was having her tonsils removed, she went into cardiac arrest, suffered extensive hemorrhaging in her brain, and was declared brain dead 3 days later. Clearly, any family would have been in shock to have received that news. However, in thinking about this talk today, I started looking at some of these issues, and I was just astounded at some of the quotes that I was hearing, aside from my own personal work in my practice. The letter that was released just this month by the family's attorney actually quotes the family, and I'm going to read some of that now in case some of you have not heard it. We have our strong religious convictions and set of beliefs, and we believe that in this country, a parent has the right to make decisions concerning the existence of their child, not a doctor who looks only at lines on paper or reads the cold black and white words on the law that says brain dead, and definitely not a doctor who runs the facility that caused the brain death in the first place. We acknowledge that the odds are stacked against us. She was dead. We know that the doctors have pronounced her dead. We heard it shouted at us 4 times. So, they were shouted that their child was dead. Marlise Munoz was declared brain dead after collapsing on the kitchen floor. Many of you are familiar with that family. And the family, who felt that they had been doing everything the way they needed to and knew her last wishes were that she did not want to be maintained on machines. They were stunned to learn that the hospital was not going to comply with their instructions because she was 14 weeks pregnant. Texas is one of more than 24 states that prohibit, with varying degrees of strictness, medical officials from cutting off life support to pregnant people. We'll remove ourselves from the abortion debate at the moment, but if we listen to the quotes from the parents, we hear once again the strains and challenges for reaching out the public and our system in understanding what death and dying and advanced care planning actually is about. We hear their cry for autonomy. It's not a matter of pro-choice or pro-life, said Mrs. Munoz's mother. It's about a matter of our daughter's wishes not being honored by the state of Texas. The father says, I get angry with the state. What business did they have delivering and delving into these areas? Why are they practicing medicine in Austin? I'm not looking to sidetrack our advanced care planning discussion here by mentioning these two situations. I became engaged in the following, both situations, because I saw on my own palliative care social work listserv the misuse of terms about life support, the mistrust expressed by families, the mistrust expressed by the African American and Latino families mirrors what we know from the literature. The handling of both of these situations speaks volumes about the misunderstandings that exist in our society, the need for educating our society at large, including our own professionals. How is it in 2014 that we're okay with using mechanical support and other measures to maintain the illusion of life when none exists? What kind of conversations are we having if our doctors are shouting at us that our child is dead? We have no shortage of research on this topic. NINR just recently released a report looking at the scientific research on end-of-life care and palliative care over this last decade. Over 3,100 scientific publications were reviewed between 1997 and 2010. Over a third of them were on advanced care planning, pain and symptom management, and care settings. And yet here we are today still having this dialogue. We know... Okay, well, my time was up, but, and I really wanted to cover, I mean, if I really wanted to take us into the weeds, I just was going to mention that in Nevada, while we have been for 40 years talking to ourselves about the fact that we need to be able to engage the public and have a movement, the movement, which as a trained palliative care clinician is not anything I would ever support publicly, as a public policy analyst would not support publicly, but there's 4 states that have death with dignity laws. So the community is on the move somewhere, and they are doing something. And there was just an issue in Nevada where a judge ruled that the court cannot envision a right more fundamental, more private, and more integral to the liberty, safety, and happiness of a New Mexican than the right of a competent, terminally ill patient to choose aid in dying. So there is many aspects of this discussion out there. One of the things, hopefully, that will come out as we have our panel discussion are some of the plans that I know that we need to put in place with the electronic health records, some of our social marketing efforts, how to embed advanced care planning in care plans, and then ultimately what we can do through things like the AAAs and the Elder Care Locator, which I noticed they just recently have partnered with the Conversation Project, and ways to get those kinds of pieces of information out. Thanks.